Ladies and gentlemen, apologies for, nevertheless, thank you so much for joining. I think we quickly get into the business and we see where to go. As I was sharing earlier, this is a series of webinars that we have planned. Last time around, we had one that focused on financing for health, particularly the aid sector. Today, we want to focus on the human resources for health. Let me just share a brief so that I can set the pace of the conversation. So the program the program, we're going to have my welcome remarks, brief welcome remarks to contextualize. I don't know whether Ravi is on call. Ravi was meant to open us up with the context of the coloniality discourse in Africa, focusing on the work that PHM is doing, but also the Kampala initiative. This is kind of work that we're doing as a collective, and a couple of organizations are pursuing this agenda, but from different perspectives. Then we shall go ahead to have my colleague, Hamim Masood, the Policy and Campaign Officer from Health Poverty Action, to share his experience and organization's experience on colonizing the health practice, primarily focusing on the struggle for indigenous medicine in Africa. And then my colleague, Comrade Gramsen Kiza, will come in to share the research finding from the Ugandan experience, looking at coloniality of the health profession education. Case of Uganda. Then Dennis Bukenya from HURIC and PHM will wrap it up with a conversation around a crisis of the human resource health in Uganda and Africa in general amidst the COVID crisis, and kind of direct to us, how do we build back better? I'm uncomfortable with that word, back better, build back better. It's also another lingua coming from another part of the world where people are claiming to be building back, but I don't think, or I don't know whether Africa is building back anyway. Then we shall have open discussion, questions coming through, and then we shall wrap it up at 3:30 Ugandan time. Wherever you are, we intend to take 2 hours of your great time. Ladies and gentlemen, thank you so much. So I will quickly get into my conversations to open up. Now, this discourse of coloniality and decoloniality is not new, but it has raised a series of questions. People are asking, what does it mean? Whose is it for? What is the priority focus? What is the end game? Does coloniality mean anything? Because what does it mean to the colonizer, the colonized? How about those that didn't colonize, but have been sort of having some queries about how the discourse is moving? Then we have the old struggle, which looks at, of course, the gender struggle, the LGBTI struggle, the climate issues, the poverty and inequities. So there is a lot of unanswered questions. So when we reflected on the discourse on how we can plug into as activists from the Global South, we met a lot of questions and people are wanting to know where our locus was in regards to the discourse. So I want to start with really the asymmetries of this conversation. Wherever you are approaching this discourse, it is true, it is okay, and we are not going to prescribe what people see or know about it, but we are saying it is important to have a space where everyone is sharing and having something to say as regards to this conversation. And this is an opportunity for us to have the voices of the people come through, especially those that interface with the grassroots. Of course, we know the aspiration is to have health getting to everyone, especially those that have been left out for so many years. They have suffered the inequities, they have struggled to be resilient because they are working in a system or surviving in a system that is unfair. Unfair not because of their own making, but unfair because of the systems that they found themselves in. Part of those inherited, part of those are remnants of the colonial past or the politics of the past that has created, a system that has the haves and the have-nots. So to start the conversation, someone would want to know why health workers, why human resources for health? So when we were looking through the challenges of the healthcare system broadly, we found that the human resource for health is very critical if we are to achieve health for all. And the influence of coloniality is indeed alive and well. For instance, let me give some statistics based on the nursing and midwifery space. The world has about 6 million shortage of nurses, and 89% of them are in low middle income countries. Most low and middle income countries are struggling with aspects of retention, probably arising from poor pay, issues of safety, career growth, working conditions, and etc. We are struggling with international migration as a good number of our health workers are migrating probably to the West or within better resourced countries, even within the region. Indeed, we are seeing that in most, especially in sub-Saharan Africa, most countries are failing to graduate sufficient numbers of human resources for health to offset those that are retiring. I need not to mention the impact of COVID and what it has done to the health sector, particularly the health workers. So with that background, we are seeing a crisis of the human resources for health that is driven by the demographics. Of course, as you know, Africa, especially sub-Saharan Africa, is a young continent, is a young countries. The disease burden, as we speak, we have triple or double burdens of disease. Historically, we suffered from non-communicable diseases, but now we're seeing non-communicable diseases that are really taking a lot of our lives. We are seeing health systems that are not well financed, a little bit backward in technologies, and then the struggle to have the right labor training of sufficient workers to get into the system to meet the needs I've shared earlier. Of course, we know there are challenges within the workforce as regards to numbers being in short supply, as I mentioned, the issues of skills, the teams not working adequately, the rural-urban divide, and the migration that I talked about. So having seen all that, and we mapped out, if you look at this map, the shortage of human resources for health is primarily in countries that were formerly colonized, or you call developing countries. And when you project the challenges of COVID in Africa, you'll see that the countries struggling with the human resource burden are the ones that are having very high difficulties in regards or high vulnerabilities as a result of COVID. So with that background, I think it is important to draw a line and extend it and say, to what extent is history playing out, especially history that is arising out of coloniality, but also the history that gives us the current context of the remnants of power and how it plays out in manifesting, defining, and distributing some of these inequities. So, ladies and gentlemen, I know the world has had a lot. For instance, the global nursing and midwifery strategy talks about strategic areas that need to be worked on to improve. For instance, strengthening education and capacity of training and quality, creating jobs for nurses, building leadership capacity, and optimizing practice. So we see that as a critical aspect in responding to the challenge. However, the conversation about the implications and challenges of coloniality are not coming through. Therefore, we want to use this opportunity to have comrades share about what is pertaining and what is it that we can dialogue. The emphasis is to have colleagues sharing how do we move from here and how do we create a better world for everyone. With that preamble, ladies and gentlemen, allow me to introduce to you the first presenter, Hamim Masood. Hamim works for, yes, Hamim, could we have your presentation up? Dennis, not you, you projected, I wanted Hamim. Hamim is a social justice campaigner and media professional and a commentator on Africa's development. He's currently the campaign's lead at Health Poverty Action and is overseeing interventions in this region. He's ensuring that mental health is mainstreamed and given priority. Previously, Hamim campaigned and supported indigenous people in communities across Africa, and he has very vast experience in integration of indigenous knowledges in health systems. Hamim's focus is going to expound on the aspect of indigenous knowledge and how it can be integrated in healthcare systems, especially in countries like ours, where majority of our people still rely on services from indigenous practitioners. Hamim, over to you. Thank you.
All right. Thank you very much, Danny, for that introduction, but also for that moving presentation that you've just made. I feel very privileged to be joining this panel to discuss one of the most pertinent issues in the development of places like Africa. As Danny has said, we still experience some of the largest burden to diseases across the globe. And that is an issue that cannot just be addressed by speeches and rhetoric, but we need to do some action. And part of that action means that we need to decolonize, okay? Somehow try to dismantle some of the power structures that are holding freedoms of people to access health, and also try to leverage some of the resources that we have at our disposal. And that is going to be the focus of my presentation. What I could also add is that in Africa, we had all the struggles to give us independence from our colonial masters, and we got that political independence. We are still struggling with several other issues that are still holding us into the practices of the past. Some of them are economic in nature, some of them are gender in nature. But like Danny has just told us, this other one here, the one that deals with health and medicines. So it's an issue that really we need to try to deal with head on and try to address so that we also can access, people on the continent can access health just like any other person across this continent. Next slide, please. Yes, so indigenous knowledge has recently been regarded as an important commodity in the health and development of human beings. Although recommendations by World Health Organizations highlight, and several other instruments highlight the importance of local knowledge and local experiences and traditional medicines, these remain rhetoric. They are not yet realized because, as we have come to learn, some of the structures, those unhidden systems, the structure that are holding some of these things in place are still in place. They need to be dismantled. So also referred to, it is also referred to as traditional medicine or alternative medicine. By definition, it is all natural health alternatives that we can use to solve some of our health issues, but also environmental issues. There are things that have been used by human beings for generations. Okay, before the advent of the modern medicine, we had a way of solving some of our health issues. These systems, these issues, and these practices have, in one way or the other, been lost. But evidence suggests that up till recently, this knowledge, the traditional medical practice, was largely a barrier to modern and progress. It has been categorized as being backward. It is being demonized. It has labels, okay? It's witchcraft, it's, there's some witch hunt around a traditional medical practitioner in some of the places we come from here in Africa. More so the indigenous communities who, I should add, rarely access some of the modern health facilities and services that most of us enjoy. So the communities who adhere to traditional belief systems and local knowledge in health were seen as uncivilized, backward. But to our surprise, even before colonialism started, a case for Uganda, the Baganda here, it's one of the largest local communities in Uganda, had a complex and effective medical system. They could even perform some operations, okay? But when colonialism set in, all these ones were demonized. They were looked up as being backward and they were thrown to the trenches. So, as you probably might be aware, the tropical medicine ideally explains some of the challenges that we face when we deal with our local traditions.
No, I have some with, and I was just replying to the email about the Wednesday, and I'm free pretty much all day. All right. So anytime should work.
Hello, sorry. Someone is, can you please mute? All right. Hello, someone, you're interrupting the conversation. Can you please mute your microphone?
Right. Let me have someone mute them here. Okay, thank you.
Okay. All right. Sorry for that interruption. Yes, but I meant to say that the tropical medicine has that colonial connection to things because it had to displace whatever Africans were trying to put in place, what they had been using for generations to cure themselves, to promote health, to all sorts of things. So it had to displace most of the things. And the process they used was, first of all, to demonize it and call it backward, and also introduce some of the Western medicine, which were good, but were not culturally appropriate some of the challenges that the communities have been facing. Like, for example, they lacked the meditation, the spiritual connections to things, and also the connection to the environment and the ecosystem, which are very, very vital to communities such as those in Africa. So we up to now still perceive global health as a top-down process that is superimposing modern medicine, like I've said, which is good, but at the cost of destroying some of the culturally appropriate, affordable systems and medicines that are in place that actually locals should be using to solve some of their challenges, and somehow help in realizing universal health coverage. So what I'm trying to argue here is that we cannot really decolonize only by changing the power structures, okay? We need also to harness and also leverage some of our own resources, our local resources, our time-tested resources, our culturally appropriate resources. They need to come in, they need to be taken to scale. They need to also be given time to try and fail. They should be given that ability for them to grow and mature and finally start to be of much help to the communities that to the communities that are having issues with health. So I'm having two examples here. One of them is the problem, most of you have heard about it, but it's the friendship bench. This is an integrated form of modern medicine, plus also the local experiences and ways of solving health challenges. It deals with mental health. So all we do is, in a referral system, starting with the grassroots, we have grandmothers who are used to deliver talk therapies, okay? Some of the conditions that do not necessarily need hospitalization. They address these issues from that level. Where they fail, they always pass now these to the higher levels in the hierarchy of the health system. And for those serious ones, normally end in the psychiatric institutions. So that is one example that shows that actually our knowledge base is very critical and is needed. What is good about this friendship bench is that it is cheap, it is affordable, it's accessible, it solves the problems very quickly, because there have been some challenges with modern medicine. It lacks that personal connection, that therapeutic connection that is needed in healing once the medicine has been prescribed. The third example involves the different courses. There are certain universities that are now putting in place courses that are meant to somehow build this knowledge, hold research, and also build capacities of Africans to exercise and practice their local solutions to the health challenges.
I mean, can you wrap up?
Yes.
Can you wrap up?
All right, so I'll go to the next conclusion, rather slide, and I'll conclude by saying that we must dismantle the power structures holding colonialism in place and impacting global health in ways that reminisce colonial legacies. But we must also harness and take to scale traditional and indigenous health systems and restore culturally appropriate ways back into the health system. The burden of disease still falls predominantly to some of our communities. We also need to bring the two worlds together. We should not look at modern medicine in isolation, and we should also not look at our traditional practices in isolation. These should complement and reinforce each other. My final slide, please. Yes, so the language also needs to be, liberated. We still have the wrong language. There's a way we still demonize, even here in Africa and in Uganda, we still demonize some of our practices. We still call our medicine people witchcraft. The places they go to are scary. We still need to change a few of those things. Then we need to conduct research and share this knowledge. Then finally, we also need to do things around intellectual property rights that remain a challenge. I thank you very much, and I look forward to an interaction with you. Back to you, Danny.
Yeah, thank you so much, Habib, for that wonderful presentation. I will request participants to drop in any questions, so we shall, at the end of all the presentations, have kind of like a question and answer session. So without further ado, I would like to invite Frank. Frank works with Innovations for Development, and he's sharing, it's sort of a paper that was developed out of the work by Innovations for Development in trying to identify legacies of coloniality in health professional education, but also proposing ways on how to deal with them. Frank, over to you quickly, 7 minutes, and then probably we'll have a reflection after that. Thank you.
Thank you, Danny, for the introduction. I'm going to present on the coloniality within health professional education in Uganda. As we all know, Uganda and Africa continue to face a hard burden of diseases, and the quality of health, HRHO, human resource for health, remains critical, and yet they are fundamental to realizing health outcomes. So we carried out a research on the coloniality or the colonial legacies within health professional education that may be hindering the work of our health workers or the human resource for health. So our objectives were to assess the manifestations of coloniality within health professional education, training, and then to identify the strategies in which we can reduce the colonial influences. Yes. Coloniality refers to the living legacies of colonialism in contemporary societies that have outlived the former colonialism and have become integrated into the social order. This is by Kujano. When we look at coloniality, it has three forms in which it expresses itself. That's coloniality of power, coloniality of knowledge, and coloniality of being. When we talk of education, we look at coloniality of knowledge, which is referred to as the repression of local knowledges or indigenous forms of knowledge of the colonized people. I'll go into the expressions of coloniality that we see within health professional education in Uganda. We have epistemicide of culture and traditional medicine. As noted by the previous speaker, our system has ignored our traditional forms of knowledge of medicine, and we value more of the Western system of education that brings out or focuses more on the Western medicine. And yet, WHO reports that 60% of people in sub-Saharan Africa actually prefer using traditional medicine as their first line of medicine or treatment. So having a health system and training of health workers that focuses only on Western medicine, it means that we are failing the population, yet because it prefers the use of traditional medicine. As you can see in the picture, traditional medicine is only limited to teachings, to informal teachings. Then the second expression we have is the decentering of indigenous languages, as noted by Ngugi. Othongo, he says language is a memory of communities and a keep of knowledge and experiences of societies, which means that the more we dissent our own languages, because we focus on English or we prioritize English as a formal language of communication and training of health workers. But then at the end of the day, these health workers have to go back to their communities and use their local languages, which means at times they find it hard to interpret information from English back to their local languages because there's no literature that translates information from English back to the local languages we use, which at times leads to poor quality services they deliver to their patients. Then when we also have a white gaze of the professional training resources, as you see in the slide, I quoted a study by INDIGENOUS, which says 4.5% of images showing dark skin are the only ones that appear within general medicine textbooks. And yet, which means that these descriptions of conditions are ignored. And we have health workers here being trained to treat populations that have dark skin, or I would say black skin, but then they're trained on images that have white skin, which means there will be certain symptoms. For example, I would give a case of measles or jaundice. Jaundice is described as giving symptoms of a yellow skin, but if you look at a dark skin or a black skin cannot turn yellow, even if the person is turning to jaundice. So if a health worker has been trained or only knows this as the only symptom, it means they are going to first misdiagnose, and maybe most of the times they treat a different condition. This at times has led to antimicrobial resistance because health workers are doing broad spectrum treatments for conditions that are not there because they are trying to guess. Then there's other expression we have is the neoliberalism and how it has distorted health profession education. When you look at this, during at the end of the 20th century, the governments in developing countries were tasked by the IMF and the World Bank to reduce the involvement in social services for certain sectors, of which of these we had health and education, and the introduction of privatization. This has seen a move where health and education is no longer conceived, they are no longer conceived as social rights, but have become mechanisms of profit and private investment. With the recent era of COVID, as you can see in the image below, a young lady lost her life because she was moved from one hospital to another because she couldn't afford to pay. This is one of the examples how privatization has affected. The other thing, one example that is directly to educational professionals, most of the private institutions focus more on the ability to pay than the quality of students they take in, which means at the end of the day, we shall have professionals that are produced that do not meet the quality that is required at some moment. Then we look at the structural marginalization of female professionals.
Frank, could you wrap up? Would you wrap up?
Okay. When you look at the structural marginalization, you look at the history of medicine, where at its introduction, certain cadreships were given to either male or female, and the lower cadreships, that's let's say nursing and midwifery, were given to females, and this has persisted within the system. As you can see, the graph shows students enrolled on diploma of nursing. It shows the females were more and the males were less. When we go to bachelors, where the cadre increases, males become more, and then we go to bachelors of medicine, we see a high number of male compared to female, which is the same case within the system. Even though World Health Organization says 70% of the health workforce are female, most of these, majority are within the lower cadres, that's nursing and midwifery, that are affected by lower pay. And then we have the hierarchy within the health profession, where it marginalizes the bottom health workers. This relates to what I've been talking about, where females are marginalized. This mode of hierarchy tends to concentrate power and resources at the higher end of the health profession, where we see a doctor is regarded as an expert, regardless of all other qualified professionals and their contributions. We have the brain drain. The last one is the brain drain of health professionals. At this, we look at the movement of health professionals from developing countries to developed countries. And there is a tendency that professionals always move from countries of their former colonizers or to countries with close ties. An example of this is that if you look at patterns of movement of health workers or health professionals from Uganda, you'll see that most of them go to England or to English-speaking countries. This is probably because they can easily plug into the system as compared to other countries that don't have close ties to England. Then I'll give a few of the implications that we have due to these expressions. We have loss of indigenous knowledges of medicine and traditional remedies. Then there's ineffective communication between the health worker and their patients because they can't interpret the language back to the local languages. Then the wide-gauged materials, they equip our professionals with less knowledge to manage conditions on Black patients because the examples they have and the symptoms they get as descriptions, they refer to a white patient, which means they will misdiagnose and mistreat. Then women's concerns are always overlooked and are often not vocalized due to underrepresentation. Then there's dissatisfaction of marginalized professionals due to the hierarchy, the levels of power. And then also this hierarchy causes poor teamwork among health professionals. And there's a divide between cadres, let's say doctors and nurses. Then when health professionals migrate, we have increased cost of training and loss of specialists and experts because they are taken up by
Frank, thank you so much. Frank, I'm going to stop you at that because of the time. We will not have questions until the end. I will urge you participants to drop the questions that they have, which you shall have in the Q&A. Dennis, can we have you come on board? Thank you.
Thank you, Doctor. Thank you, Danny. Please allow me share my screen.
Go ahead. Before Dennis starts, Dennis is a human rights lawyer and a graduate of Makerere University School of Law. He's the executive director of the Human Resource Documentation Center, and he heads the People's Health Movement in Uganda. Dennis, please join us. Thank you so much.
Thank you so much, Danny, for that kind introduction. And thank you, everyone, for listening in to us. So I'm basically going to talk about the crisis of human resources for health in Uganda that actually is reflected in many places in Africa. So I will give the example of what Uganda is going through and then reflect in a few areas how it is all about issues of coloniality. So where are we and how did we arrive at where we are today? Today, we we have spent over 16,240 US dollars in training health professionals. But then the question now arises as to where are they, because we have lots of shortages. Yeah. And the biggest answer to this has been issues of immigration of these health workers. So when we train them, they migrate. Maybe people are saying that the country, Uganda, maybe many African countries cannot absorb the human resources they train. But I really think the issue has been immigration. And why immigration? I think it is more about the job insecurity. And it is very interesting that many a time you'll find that their families where they live and the governments are encouraging them to migrate. In Uganda, we have a whole ministry that actually focuses on how people migrate for better work. And you can understand, because I mean, we're a poor country, so probably the remittances and the flow of foreign currency may be a factor that encourages. So briefly, Uganda is among the 57 countries with shortages in HRH. And you find that, for instance, in Uganda, you'll find the ratios very, very interesting. That the WHO encourages us to have one health professional for 439, but in Uganda it is one for 1,818. And then we also in Uganda have over 2,919 physicians. But when you do the ratios, you find that with that number of physicians, you have one physician who is dealing with almost 8,373 people. So what is the status in all this? When you include all, the current situation in Uganda, it is only logical to include every person who is, say, under the HR, human resources for health, like the laboratory staff, theater staff, orthopedics. The ratios are, you find that Uganda has only one employed professional or health worker for every 1,000 inhabitants. And why is this? For me, I take this back to the education system, and that's why I gave how much money has been sunk into training these health professionals. So the training in its own self, the structures in which it was created and how it is embedded to support the health system in itself is colonial. Yeah. So Uganda has defined staffing norms based on the prescribed positions for each cadre. If you look at it, without immigration, this works perfectly well. But the staffing norms were created ages back. We are now in almost 2 decades when the staffing norms were created. We had a population then of probably 21 million, but now Uganda is 41 million. And this, I think, works for many, happens in many other African countries. So the issue of immigration, again, of health professionals enlarges the workforce gap. Let's look at what happened when we got the pandemic. In Uganda today, Uganda is a unique country where you find a public hospital which has a private wing. So when a person goes to a private wing, they will get attention, they will get medication, they will be met by a physician. But when that very person probably tried to go to the public wing, you will not find, if you find a health professional, you will be very lucky. And if you find that health profession, you will not, in fact, get the medication you want. They will refer you to somewhere where to get the medication from. So it becomes a very confusing aspect. And this was heavily exposed by the pandemic, because then in the pandemic, you find that there was shortage of health workers generally. But also the health workers were looking for where they could make better money. So the people in the public sectors were abandoned. And that is why you have seen many people writing about the situation of having no cylinders for oxygen, no medication, people dying every day in such big numbers. But again, for me, it comes back to the training that these people have undergone. So the health professionals themselves also had challenges because there were very few. You find that they also were affected because of the numbers they were handling. Many of them died in this pandemic. Maybe because of exhaustion, maybe because the government did not actually provide the PPEs. But when you go to the private sector, all these things are there. So what I think, when you building a health workforce that responds to the population needs is key. And looking at these staffing norms, I have already told you that the staffing norms were okay in the start, but because of the increase of the population, they were not built to kind of support the growth of the population. So today you find a situation. So today you find a situation in Uganda that the training we get, because it is colonial in nature, it does not train the students or the people how to become innovative. It is mainly a copy and paste. That is why you find the whole ministry has a strategic plan that is supposed to work for 2 decades backwards, but it is still working today. And when you go to the ministry, they will tell you because of our staffing norms, it is perfectly okay. But then you ask them, why are some hospitals not having these health professionals? So again, looking at another issue I want to raise is lack of the accurate, reliable, standard, and timely data of health workers at national and subnational levels. The Ministry of Health does not have some of these records, and I think that one is also affecting. They don't know who they have trained, how that person has moved through the system, and where they can't track where those people are. Many of them have gone to the diaspora. So I think it is important for the government to disperse resources timely to the ministry so that they can have all these systems in place and be able again to absorb, train, so that they train purposefully. Another issue that I think we are getting is the fact that there are so many donations that come to the Ministry of Health. So the government has decided to say, we don't have to put much money into the Ministry of Health because it already has alternatives. Okay, so the mobilized domestic resources are not in any way pinched into the health system. And I think that is what it should be.
Dennis, I'm going to ask you to wrap up so that we can open up the conversation.
So in conclusion, therefore, allow me to say that the main problems regarding HRH stems from the management and the training that these people have had. I think all that lies in management. We have low staffing and maldistribution. We have attritions and brain drain recommendations that we need to work upon them. And then, of course, there is need to improve the improvement in HRH management and overall strengthening of health systems. Again, there is need to improve the work and living conditions of these health workers to encourage them to stay and work home. Thank you, everybody. I will welcome your questions, comments, and redirections.
Thank you so much, Dennis, for that sharing. I now invite participants to, drop in questions, comments, and we chat. This is a dialogue that we do not want to own, and indeed we shouldn't own. We come from a place where we believe in solidarity. As I shared in the beginning, the discourse of decoloniality and coloniality in general has kind of raised a lot of attention, and some people feel left out, especially in how it is structured, the voices that are permitted to permeate through. and the conversations and how they are shaped. So you don't want to create another ownership of a buzzword, but we want it to be a collective kind of shared and participatory kind of discourse so that everyone has something to say. So with that, I would like to have the team, first of all, answer the questions quickly, but then also open the conversation to some of the participants who might have something to share in regards to the topic. I have just left a couple of questions on the slides here. How do we move forward? What are the critical steps to decolonize the human resources for health that we can pick? Have we failed in, okay, yes, it is true because we are having challenges today. It is eminent that we failed. How did we fail? What can we learn from our failures? Then given the context of COVID and the pressures that this has created on the human resources for health, how do we build back better? Because I envisage that when the world opens up, many of the health workers that I know have been dismayed by COVID, and some are really willing to look out for greener pastures elsewhere. I have many colleagues of mine who are doctors driving Uber in the US. Can you imagine? They left as professionals, but they were not absorbed by the Western systems. They are driving Uber or looking after our elderly populations in Europe. So this is the crisis that we have. How do we get past that? Ladies and gentlemen, I'm opening up the conversation. If you are ready, you can just flag your hand and then you can give an opportunity. If you have a question, then you can quickly bring it out to the participants. Hello? Am I not seeing questions coming through? Maybe let me, yeah. Okay, I'm asking my colleagues here to give me the questions that have come through. But as they come, if there is anyone ready to have a say, please raise your hand. I'll give you an opportunity. Then you can unmute yourself and we proceed with the conversation. Thank you. Okay, my question is, how do we Africans go back to the good old days? Our forefathers have traditional medicine. Why did we jettison them to a borrowed system where we have been learning for ages without much success? Also, Westernization have made our politics monetized. Now, who will help us to go back to a believed outcome? Hamim, this is yours. How do we get back to the good old days? I don't know whether they were good old days. I wasn't there. But sometimes the numbers don't tell that story. Over to you. What do you have to say? Do we need to go back?
Thanks a lot. I think we had the missed opportunity over time to build on our knowledge and perfect it. So the modern medicine had that privilege. We didn't have that. And again, also we as Africans and also our medicines, we also have our own pitfalls there. And we have, manipulations, we have fake, practitioners within us. But like, and you'll agree with me, that's an issue of regulation. And it's happening because it's in the cover of the duck. It's not yet been brought out and put in the right place so that it can be protected and taken up. But going back, we had very little chance to take whatever we were using, to the next level. I'll give an example of the forest people here in Africa and in Uganda in particular. We have the Batwa, they stay in southwestern Uganda. And the ancestral lands are the current Bwindi impenetrable forests, okay, and Muhavura. These forests, okay, rather, these communities, the Batwa, are the earliest known people to occupy the Great Lakes region. They had used the medicine, shrubs, and meditation, and everything from those forests to treat most of the ailments that they always had. They were never perfect, but at least they managed to survive up to the time that we managed to meet with them. Okay, so when colonialism came in, the lands were taken away and turned into reserves and national parks. The impact is that the places where they used to go and do meditation, for example, their connection with the spirits, the spiritual connection was lost. Then secondly, they were considered poachers and trespassers every time they wanted to go back to the forests and pick the shrubs. So this, if you go now to those places where the Batwa stay, they still up to this day live in abject poverty on the boundaries of territories that used to be their own. They can no longer access primary, health care. Most of them are not immunized for these basic, polio, things that most Ugandans are taking for granted. But this is the impact of colonialism. But I should also add and say that we shouldn't put much blame on European colonialism because it left. We still have systems up till today that still carry forward that sort of practice. And that explains the status of the Batwa up to this moment. Thank you.
Yes, Habib, you've shared a very important point there, because one of the challenges that I've had following up this agenda is the rigidity of the African health systems to even comprehend the realities. The clamor to associate with the Western academia, with what has been prioritized as the agenda, is very critical. And for me, the question then would be, how do we make our people in this part of the world to understand even some of these discourses? Because in the colonial discourse and coloniality, I have been into offices in the country in Uganda, and people look at me as sabotaging aid. For instance, that I'm sabotaging opportunities for aid to flow in Uganda by awakening the public. How do we engage, especially within the health sector, to have these people who have been oriented to think in a particular way, to open up and say, for instance, indigenous medicine has a role, integrating it in the learnings by health workers, or the language, or some of the good practices, or even investing in research to see some of the practices, whether they meet the scientific or, requirements for them to be integrated. How do we move past that?
Okay, so if I may chip in very quickly, I would think the process of doctrination takes a while, and also it takes a while to remove that doctrination, and that has been the magic, that has been the practice of colonial. So they went to our education systems, okay, the curriculums, and they were changed and were taught to believe that West is best and everything African was wrong and backward. So that mentality is still in place. We still are still being taught using the same curriculums. Very little has changed. So we need first to go back and start when we're still very young. How are we socializing our young people who are going to be the leaders and practitioners in health institutions for tomorrow? We need to start there and change. And also we need to be a little bit patient to know that there are things we might have wins, quick wins, but this war is prolonged. It's going to be, we should be, humble enough and strategic to set long-term goals and try to solve some of them may be generational, but there are those that we need to fix very quickly. So that is my thought, Danny, about that.
Okay, thank you. I still want hands raised up. If you have any question, just flag your hand, I will see you, and then you can unmute yourself and ask your question. So now I open up the discussion. If there's somebody who has a comment to make in respect to the conversation happening, please feel free to raise your hand as I keep looking through the comments or questions in the chat. Thank you. Yes, Dennis, as we wait for the hands to come through, you have articulated the weaknesses within the system. And the song of having a better system has been around for quite some time. Oh, yes, I am seeing a hand. Linda, thank you so much for joining us. Can we have your question or comment? Unmute yourself, you can unmute yourself. Prof. Linda Gibson, can you go ahead with the question or comment? Hello? I think she's not hearing me. Linda Gibson, go ahead with your question or comment. I think, okay, Dennis, could you pick it from there as we wait for Linda to
Sorry, you didn't finish the question.
I'm saying that your sharing reflected a failed health system. We seem to have the same conversation. How do we really build a critical mass of, for instance, people that see what you advocates are seeing, so that transformational change happens?
Thank you very much, moderator. I think the one thing we need to do is all of us, first of all, understand what it is that we want to change. And what we are saying is that the coloniality is affecting the efficiency in the system. And we are trying to highlight the coloniality. So one, I think we need to, first of all, to create the mass, we need to work together, not to work in silos. Because I think that has been a problem, that because we are all working at different stages of this whole issue, everybody perceives it differently. So we have a challenge that people, in fact, think that what we are doing is to try and stop aid from supporting the system. So first of all, we need to understand what it is. We need to, first of all, communicate ably what it is that we think should change. And then after that, we give practical examples or solutions to what we think will help or create change. And then also, we try to go to the cause of the challenges. For instance, when you talk about the education system, who is in charge of the education system? Unfortunately, in Uganda, it may be such a difficult thing because of the powers that be, but still it doesn't stop us from publishing, from engaging with these players and showing them the challenges that the education system is causing. And highlighting small things or issues like, if you're educating somebody to immigrate, can you at least bond them in that education system? That why are you educating so many, yet you cannot absorb them as a system? Can you educate a few perfectly and give them the proper education system that the population needs? And then you staff them. Yeah. But I think, again, we need to think about issues of corruption that are within. That because of corruption, some of these things are supported. So probably we also need to go to players who are fighting against corruption, and we try to highlight to them what corruption is doing, that it is maintaining a problem that only takes us nowhere, but only helps a few to help themselves.
Okay, thank you, Dennis. Linda has a question. How does Uganda, Africa take control of the economic, political, cultural dynamics that work systematically or systemically through, for example, the internal actors and agencies of health that are at work? Hamim, could we share here? Because, I mean, for many years, Africa has been singing the same song. Our friends in the North, especially the allies and comrades who want to see Africa shift and change, are saying, and indeed it is true, the inherent challenges and problems within our context that we must defeat if we are going to decolonize in general. I have seen the last time I talked about the ideological disorientation, the wrong priorities, the wrong investment, the corruption, and so many things that are eating away all the resources that would have used to invest in health. So how can Africa take control of the economics, the politics, and the dynamics of culture that you have ably illustrated? And I would really want you to give critical examples, probably in any other sub-Saharan African country where there's been some success, if you could point out that.
All right, thanks a lot for that question, Gibson, and for the elaboration, Danny. Yeah, so we really have come a long way, and to be honest, as a community and as a continent, we have achieved so much. Okay, from from issues to do with addressing communicable diseases, and to a level where now we are struggling with issues that are a little bit higher, no longer lower. So we have come a long way, and there is a way we need to approach what is remaining to be addressed. And for some time, countries had gone their ways. So Uganda wanted to be an island, same with Kenya, and they wanted to solve most of these things on their own. But they're realizing that that is not going to happen. The change is not going to happen very quickly. And so there's that integration. And it is happening very quickly. And at regional level, if you come to East Africa, we have the East African Bloc, we also have the SADC, the Southern African Development Corporation. In the West, we have ECOWAS, and in the North, the same thing. And this is not just about integrating economies of countries. It is also about integrating such policies that we had that need to bring us to a situation where we are able to address some of the issues that you have raised, those of health, those of education, those of everything, and those ones are happening very quickly. So there's that momentum going on, but and that is being coordinated by the African Union, which is a good thing. But we also need to be aware that there are certain forces beyond us as Africans or as countries that are still at play. And these ones need to be played. And that's what you said clearly, Danny, that we need to work in solidarity with the citizens across the globe. So we need to create a movement, okay, with people, with citizens in the UK, in Europe, in Canada, and everywhere. And we try to address some of these issues because, like COVID has taught us, no country is an island. The challenges that we are facing here in Uganda are ending up at the doorsteps of countries in the North, in Canada, and where they're struggling with migration, they're struggling with all sorts of things. And most of these immigrants are coming from countries like ours here in Uganda. So it is to the benefit of countries and citizens in those respective countries to really join hands and start demanding from their governments that some of these issues, some of them are debt traps. Okay, we are trapped by the debts, and also the undemocratic makeup of the global institutions like World Bank, World Health Organization, IMF, name them. Okay, we are not represented there. So most of these things need to be put right so that we are able to address the things from our own view. But at the moment, it's top down. Things are coming out from the North and dropping down to us here, and they're not solving anything. The other second thing that we're fighting with are some of the activities of the multi-country and multilateral organizations. They are coming here in Uganda and in Africa at large. They come and exploit the resources, and they don't pay taxes, okay? When they don't pay taxes, they take this money back to the UK, to France, and this is the money that we're supposed to be using to fix our own health systems. So it is incumbent upon some of the citizens elsewhere to join hands, to build that solidarity to ask some of these questions. And the list is long. So it goes beyond the debt traps, the activities of multilateral organizations, but we also can talk about issues of these offshore accounts where actors in the north are able to come in Uganda here and bank money and do all sorts of things and then leave and do also, so there's a lot. And those things, like you are aware, are the root causes of poor health. So at Health Poverty Action, we always argue and say the global roots of poor health and poverty are in colonialism and the legacies that still hold it in place. So after giving that long speech, let me end it here and let others also contribute. Thank you.
I agree with you, and I must emphasize the connection of parts. And from the long work that I've been having within the space of healthcare, I've realized that healthcare, or the lack of it, is a consequence of the failures of other, systems or other structures that have failed. For instance, jobs, housing, what we used to call social determinants of health. So, but they manifest with, people coming in as sick just because they are poor or whatever. Thank you so much for highlighting the fact that there are connections that are there for the inequities to manifest themselves. I want to give an opportunity for Ravi to talk about the work that the Kampala Initiative is doing in pursuance of this decolonial agenda. So the kind of network and platform they are trying to create in solidarity with some of the conversations that are happening. I must also underline that this webinar is, the webinars are coming to you in collaboration with the Kampala Initiative and the People's Health Movement. And we must recognize the support that we're having from Open Society Foundation. Ravi, if you're there, please unmute yourself and make your sharing.
Thank you very much, Danny. As many of you know, I see quite a few people from the Kampala Initiative in this webinar. In the Kampala Initiative, we're very much oriented towards exploring alternative models to development assistance for health or health aid. And in this context, we're seeing how to come up with decolonialized models for health aid. Specific to the webinar that we're focusing on the health workforce, I think we should acknowledge that the current model for development assistance for health really does channel health workers away from local needs, away from local traditions. Lizzie and others have talked about indigenous models. Hamima has explored that quite a bit. And it's not acknowledged by foreign donors. So when resources come in, the structuring of the health system is very much geared toward putting the health workforce toward priorities that have been set by foreign donors. That replicates a colonial model. And so if we're looking at decolonializing the health workforce, we need to see how can we change how the resources are allocated, and that includes development assistance for health. So that's a clear role where the Kampala Initiative has an interest in the health workforce and other aspects of the health system. If you'll allow me, Danny, I'll just add one more point that there's also the Health Workers for All Coalition.
Go ahead.
Yeah, thank you. It's another civil society network with overlapping membership. And we're also looking at similar issues here. So I encourage you all very much. I'll put a link into the chat for the Health Workers for All Coalition. And let's see if we can build on the discussions today in other contexts and share these ideas broadly. Let me stop there. I can see some hands are going up, and I think it'll be very useful to have further discussion, but I'll add more in the chat. Thank you, Danny.
Thomas, go ahead. Thomas, Medicus Mundi International. Go ahead, please.
Yes, thanks. And also thanks, to Ravi for introducing both the Kampala Initiative and the Health Workers for All Coalition. From my perspective of Health Workers for All Coalition, and also related to the role of aid or health cooperation, I wonder if somebody can address the issue or the topic of community health workforce. You know, community health and community health workers, in a way, they are a pet of international cooperation. It is quite easy for international NGOs to support local community health structures, so they don't need to care for the national health system. So they have their island or their place to invest their money, to have everything under control, and therefore also the boom or the role of community health workers has strongly been reinforced also by international cooperation, but in a disintegrated sense. You know, community health and community health workers would have such a potential of contributing to a national health system, to primary health care, also with their roots sometimes in traditional medicines, but they are not linked. They are not formally integrated in a national health system. And I think this is in reality you also see in Uganda. So, well, this is a remark, but maybe some of the panelists could also react on that one. Thanks.
Okay, thank you, Thomas. Just one quick announcement. We will, in September, we shall have yet another webinar, and it will focus on the decolonizing health research in Africa. Please reach out to us if you wish to have a slot to share something. We don't want to own the presentation. If there is anybody who wants to share something, experience or lessons that we can learn from their works, please go ahead to share. I really need to give an opportunity to the presenters, panelists, to give their wrap-up comments. I start with you, Frank. Looking at what you have presented, the aspects of coloniality within the human resources for health, particularly the professional education, how do we go from here? What recommendations could you have seen people give in regards to decolonizing the training of health workers, particularly as the activists or people working in the space? I give you 2 minutes.
Okay, thank you, Danny. Yes, decolonizing human resource for health. When you look at the discourse for decolonization, in particular to human resources for health, most of the manifestations, we need to first accept them as ourselves, we as Ugandans, Africans, that these things are happening within us, because we have groups that are of what I would say like elites that do not agree that these things are happening. So the first step we need to take is to create the awareness, and we have people accept that this is a problem and we accept that it's happening. Then we engage as civil society. We need to lead the movement in creating awareness. Then we engage the policymakers. Yes, our governments at times, the policymakers and legislators at times can be a problem, but the more you push them, you get results slowly by slowly. So we push for involvement of, let's say, traditional medicine and knowledges of medicine into the practice or the training of health workers, engage the local practitioners and not dehumanize them, as Hamim presented that we have termed them as witchcraft practitioners. We should, as Africans or Ugandans, we should stop such practices and we say go forward as we are creating the awareness here as our people accept this. Thank you.
Thank you. Dennis, you talked about, I know you coming from PHM and the experience that you have in movement building. this discourse of decolonization is a bit fragmented, in my opinion, a little bit misunderstood, and it has different layers to it. But all of it leads to power. And of course, you know that power fights back. It is not something that you can easily push. So from you in your conclusive remarks, how do we attempt to dismantle power, but also build, a strong, formidable force that understands that all these parts are connected, and we need to engage to address the elements of power that have persisted and created the current realities that we are struggling with in the world today?
Thank you, Danny. So the movement, People's Health Movement, indeed has done a lot of work about issues of decolonizing the health systems around the globe. And if you checked, we have so many presentations on our website and articles that talk about this issue in different ways. But what I think now we need is what Kampala Initiative has. Now, Kampala Initiative creates the platform for all of those people who are interested in trying to decolonize, to decolonize the narrative. I would say it may be impossible to decolonize aid, but the narrative can be decolonized. So our focus should lie on the narrative. And we try to decolonize it in all facets possible, which Kampala Initiative does so well. And then with that, we create a mass, we create and we first of all build the people's confidence in this by telling them what it is and what it is doing. And then we bring them together so that everybody's idea can only be, the narrative can be decolonized. Most importantly, I want to go to the issue of aid, because I think official development assistance has been a problem for so long. When you look at how it works in Africa, maybe Uganda, when any institution wants to fund, they find characteristically, they find something or projects to fund. And after the project, whatever they have achieved is left to hang. And that is what we need to decolonize and say, if you're going to fund, can you work as partners? Can you work as partners with the people you would want to fund? Not look at them as people who need handouts, but partners who you want to work with and improve the situation. Like Hamimu said, most of these people you find running and crossing the Black Sea or whichever place to try and get into Europe, it is to find hope. So then we give hope to the people who don't have it by that aid going to them and working for them. And then from that, I think we shall have to decolonize the narrative. And that is what the People's Health Movement also has been trying to do over the time. Thank you, Dr.
Thank you, Dennis. Just to make a comment, early in the mid half of this year, we were doing some work on following up the money. And we identified that some money, and I'm sharing this reservedly, was coming in Uganda as aid, a loan facility, and we got wind that it was being wired out of the country by certain actors within who are high up in the structures of power. And when we asked questions, the repercussions nearly made us hide underground. So there are realities there, there's collateral damage in doing this work because power is really something that is formidable. Hamim, looking at your work, especially with your organization, and seeing the risks involved in countering this power and the expressions that I've just shared. How do we go about that, and probably remarks in regards to indigenous medicine?
Okay, thank you very much. So alongside dismantling the power structures that Dennis has just highlighted, I think we need to pay much attention on leveraging some of our very own homegrown local resources. And that means trying to build back what was destroyed during our historical relationships with the colonialism. Then I have just learned from Linda, one of our audience members, that there are several movements taking place, okay, outside Uganda that are talking about decolonization. So we need to embed in some of these narratives around indigenous knowledge. I think that's very critical. We need to take it alongside other demands, alongside other calls to actions that we are making. Then I think for partners who are funding health in Africa, I think it's high time that you need to see things differently and start to listen to the voices on the ground. Listen to that radical voices like you have heard here on this call. I think we've been a little bit radical and hard-hitting, but I think these are the representation of what is actually needed, what is on the ground. I'm not discrediting what is already out there, but I think it makes a very big difference if you listen to that frontline person. It may be that magic bullet that ends all the challenges that we're having. Then here in Uganda, I think we need to reorient our education systems and practices and embed in some of our pride, the things that have held us together for generations. Those medicines, the practices, the practitioners, the places where they practice from, all these ones need to be looked into, are developed, and also and put into teaching curricula at primary level, but also at teacher teaching levels, and as well as at universities where we train our doctors. Finally, so the last 2 points for me would also include building a knowledge base. We have a lot going on, but it's all scattered all over the place. I just gave the example of the friendship bench in Zimbabwe. I'm sure many people on this call, just a few probably already are aware of it, but it's doing wonders in Zimbabwe without the need of building Butabika, okay, the psychiatric institution where people are being confined and they're facing human rights violation and stuff like that. People are healing in their communities. So we need to look out for those cases that are working, okay? And then, learn from them and take them to scale. Then finally, we need to mainstream traditional medicine practices into primary healthcare. I think Thomas touched on that, but I think it's very critical because traditional and indigenous medicines are a little bit proactive. We don't treat only. We try to prevent, we try to create environments that make people healthy. And that's why indigenous communities will value their ecosystems, they will value their land, they will value everything that is around them because they know all that is important to their survival. So we need to embed these ones probably in the primary health care systems. So in a nutshell, that's how I could make my final remarks.
Okay, thank you on your final remarks. Ladies and gentlemen, we still have 30 more minutes. Now I open up the plenary. If you have anything you want to share, I don't want the panelists to say anything. This is your time. Please make your comment. Touch the elephant from wherever your hands can reach. If you touch the tail, go for it. I'm waiting for hands. Hands, please. I will not restrict the focus of your comments, but most primarily, if you could touch the aspect of, all of us coming together. I know the Kampala Initiative is doing a lot of work, and I will encourage you to come and join. Yes, go ahead, Ofra. You can unmute yourself. Good.
Thank you. Thank you for having me here. I know that NGOs are the best facilitators in order to promote issues. I'm from patient fertility in Israel. I'm in the member of Fertility Europe board, and I have a huge very fertile connection to Joyce Fertility NGO in Uganda, with the name of with the head of Mrs. Rita Sembuya, and together we are doing a lot in order to promote or prevent issues in our field of fertility, but it also connected to STDs and so on. So it is what I want to say, that the prevention of illness is the most important thing, and I hope that we can forward this as one of our goals: preventing, preventing, preventing. Thank you very much for having me, and thank you very much for doing that.
Thank you so much. Preventing, preventing, preventing. I hear you loud and clear. It will save a lot, especially the resources that we are struggling to have. And, you know, say hello to the people of Israel. We're glad to have you. I need to see another hand, please. Let's, come on, don't be shy. Let's give us your opinion. Even if it is to say hello or bye-bye, it's fine. I need to see a hand. Go ahead, show me a hand. Show me a hand, show me a hand. I'm not seeing comments down here. Show me a hand. What about more partners? Okay. Oh, that's what Chen was looking at. I think it is important. We need to continue to have the partnership, and then also plug into whatever is happening across the world. As Innovations for Development, our intention now going forward, we have seen, you know, documented and come up with key findings. I think now the question is, how do we now move forward, especially building a coalition of civil society that is understanding these issues, that is not bending to the whims of power and tweaking or investing in interventions that are adding no value and are not really reaching out to the communities that they serve. I think our next agenda is to see how we can build a movement within Uganda, but also empower civil society, because I feel they are too timid to engage, or they fear to annoy their backers from the different parts of the world. And then the aspect, I have had conversations with the very high up people in development programs like USAID, and then some embassies from Northern Europe, the Scandinavian countries. They are receptive to the conversation, and they seem to be saying that we've been waiting for you. I think we also need to see how we create inroads of communication to reach out to these people who seem to understand the challenges and are willing to participate and engage to make development better. Julius, I see your hand. Please go ahead and share what you have. Julius Sebuyungo. Yeah, Julius Sebuyungo. It's a Ugandan name. Sorry. Julius, go ahead if you've heard my voice. Unmute yourself and go ahead. Oh, I don't know. Julius is not sharing. Okay, another hand if Julius is not able to unmute himself. I don't know. Hello. Julius is not able to unmute himself. We could have another person share something. Please. Okay. All right. Okay. Linda has a problem with the mic. Linda, we've missed you. Linda Gibson, so much. I follow your works, especially on community health workers. You inspire me a lot. Thank you so much for joining us. Greetings to whoever you can talk to in the UK. Another hand, I'm not seeing a hand yet. Come on, people. I didn't want us to make it a monologue. We have to open it up for people to discuss. Yes, someone is saying, thanks for another interesting one, but no female panelists. Yes, we were hoping to have colleagues from ACHEST. Those of you who know ACHEST, we had booked one of the key actors, Dr. Kiguli, but of course, the date coincided with another engagement that ACHEST is doing. As you know, ACHEST is doing a lot of work on this agenda of human resources for health. So they were not able to join us. But indeed, we also saw that we don't need to promote gender insensitive engagements that do not give a platform. But then also we had some of our nurse practitioner to give the perspective of the health workers and the nursing fraternity. But 2 weeks back, I think he contracted COVID and couldn't join us. So Dennis, I see your hand up. Could you say something quickly?
Yes, my apologies. I know you had said we don't say more, but since people are not putting up their hands, maybe I can give them an idea to talk about. So allow me to say something small about community health workers. Community health workers, in many perspectives, for me, represent the issue of decolonizing health systems at the grassroots. If health systems at the grassroots are not decolonized, then you will have issues to do with lack of participation. I have been working around community participation for so many years, and what I have seen, when you go to communities and try to engage them to have community participation, you'll have a challenge. Many of them will be political. They will say political things and not necessarily touch the issues of their health challenges. Like, why are they no longer practicing primary health care? You know? So what I have realized is the fact that we, in fact, like Thomas said, need to go to the grassroots and look at this, the first health system that we have, which is the community health workers, and find a way of creating a linkage that is acceptable to the government, or the government, or work with the government, or advocate that the government, or seek that the government recognizes these people. Because I think that is the way we can start to decolonize the health system. And if the government can, first of all, take responsibility that if there's negligence arising from community health workers, they are their payroll people. But now the government in structures of the health system recognizes them, but because there is no, because of so much coloniality, it does not in any way account for their negligence, account for their remuneration and other things. So you have them now working for those who would care to fund their work. Like, say, if an organization comes in a community and it funds their work, then they use them. But the local councils go ahead and actually pick these people. I think they do it every time, every after 5 years, they select a new team, and then you wonder why they're doing this. But when you look at the work of community health workers, they are very, very good to have in the system, because they bring the system down to the government, to the grassroots, and they make the people understand what the government is trying to achieve in health systems. So I think we need to decolonize, first of all, the system that fails to enumerate them, to recognize them, and to actually train them on what they're supposed to do. And then that way, you will in fact have what we used to have as primary health care working for us. I just wanted to say something small on that. Thank you, Danny.
Thank you, Dennis. Dr. Heilu from Ethiopia, thank you so much for your comments. You were saying, I think it is high time that we should give due emphasis and see how we can take this agenda forward at a global level across the continents. beyond Africa. Let's talk the talk by having a global coalition or movement, decolonizing, development, health. Thanks so much for the great presentation and discussion. Yosha from Ethiopia. Thank you so much. We wish you well in Ethiopia. We are cognizant of the challenges that you are having recently and the conflict therein. We're in solidarity. We hope this can be resolved, because unnecessary blood is being spilled just because of politics. And we really condemn the suffering and the struggles of the people of Ethiopia, especially in Tigray. Thank you so much. Yes, I want to read. Julius, of course, noted the microphone not having doing him justice, but he mentions that he would like to see leaders in the Ugandan health sector getting involved in these webinars. I think that is one of the very good critical feedback that we are getting. We've had a little bit of resistance, I must be very honest with you, in having people understand our intention of having conversation about decolonization. Because even when we try to explain it, people cherry pick what they want to understand. For, of course, you know the fear of politics. Much of the discourse in the world, not only Africa, is defined by the politics and capital. In Europe, we see politics subordinate to capital. That's why we see a lot of these challenges in, how capital defines what gets invested, who gets what. And in Africa, we see politics overrides even common intelligence, where you have leaders deliberately refusing to either participate or engage for their own reasons. I think it's a call on us, civil society, to continue finding practical ways on how we can engage politics in Africa, because that's the low-hanging fruit. How can we have better governments? Because without good governments, you can't have good healthcare. You can't have the right investment. You can't stop corruption. You can't stop bad negotiations with the, Western companies that are really, really deliberately done to fleece the, countries. We are now having a windfall of oil, but the opacity that is in those contracts that are happening. And yet we're all looking forward to see oil coming in to bring the resources. I was talking about the aspect of aid. Government is really, really opaque around even giving information on how much money they have borrowed and how much they have used. But we know that a lot of resources are being wasted, and some of it is wired back to wherever. And some of the friends or allies inside are giving us the information, but the system is still, like Dennis put it, very resistant. And of course, the elements of coloniality, everyone wants power. So we need to find critical and better ways to engage. And the solidarity that we need from our allies in the North, especially on illicit money flows, they can give us this information and we follow it up. We follow the culprits of the Africans or their colleagues who are hiding money in Europe. But you see all over the place, in the UK, in Switzerland, in France, wherever Africans are hiding money. And they are not investing it in Africa because it was ill-gotten. Anyways, thank you so much, everyone. I need to see another hand. We still have a few minutes. We are ending at 1:30. So any comment? Please, I want to give you the chance to say something. Linda, thanks for sharing your email. I will drop an email to you. Sorry, Julius, I can see your face, but your microphone, I can't hear it. Anyone with a comment or a suggestion or input into the conversation? Let me see. To agree with Dr. Tila. Thank you so very much to the organizers and the speakers of this webinar. The insights and learnings made me truly appreciate being part of PHM as a global movement. I have problems with my internet connection. I think we need to decolonize internet as a matter of urgency because it is creating us issues that we do not want. The distance is important, but thank you for that comment, Marilyn. Yes. When is the next meeting? The next meeting is on the 21st of September. We are going to focus on health research. It's a very huge area where we want to interrogate the aspects of coloniality within research. The current COVID context gives us a perspective and reality of, we know the history of research from this part of the world, how research, of course, has been used to, create all sorts of suffering to the people. And then, of course, the current reality of intellectual property rights, the access to this research information, the participation of our people in the research endeavor, all those elements of coloniality, we want to unpack them, but most importantly, build a conversation that speaks about how do we move past this. I mean, we want to come to a webinar where we are not talking about challenges and we are only sharing opportunities and successes. How do we get there? How do we coalesce as people that have similar intentions to build a movement that is focused, resilient, and driven to see change? As you know, if you have been around for some time, most of the discourses are moved by wind. Today you are talking of these rights, tomorrow decolonization, another time this, another time. So we tend to lose focus. We tend to move by the trends. And those trends are set by those with the power. As you can see, yes, we're talking about COVID access to vaccines now. Tomorrow it's going to be climate change. If those with power flip the coin and say, maybe let's throw them an agenda, and then we run as civil society on a particular agenda. We don't seem to be consistent with our engagements, and then it demotivates some of our allies who feel that maybe out of burnout or out of some of the consequences which come with doing this work. So I think we will talk about that. And if there is anybody who wants to participate, we will create an opportunity for you to share your experiences around decolonizing health research, particularly Linda, who is coming from a university setting in the global north. How are you doing that? I know you are doing a lot of work with the academia, the trainings and the teaching, but we need to hear how does it go beyond, especially giving space to the colonized in the research space. I was reading an article this morning within the Lancet, and I saw the publications about COVID from Africa are less than 4%. It's quite amazing. It's like COVID is a disease in the north. Why are Africans not either given space, or what is the problem? I think there's so much that research can do in terms of creating a fair space and platform for everyone to engage. Ladies and gentlemen, I want to say that, yes, now that there are no comments, or maybe let me read some Dorcas, good to read. Let me read something from you. In Kenya, we have two legislations at the National Assembly and Senate that will address recognition and remuneration of community health workers. At the county level, we have county governments that have already passed legislation that recognize and are giving regular stipend to community health workers. Something AMREF Health Africa in Kenya is pushing. I think this conversation of community health workers is interesting. One of my dear friends, Dr. Kadaba, once asked me when we were having this, I'm sure most of you know him. He asked me a very powerful question. some time back, would you take your mother to a community health worker when he's sick? And then I pondered a bit, and then I told him maybe depending on the health issue that he has, I would or would not. And then he said, if you are not going to take your mother to the community health worker, why would you want others to do it? It made me to reflect and said, okay, as we are pursuing the community health worker, how much are we undermining the legitimate cry to employ more midwives, more nurses, train more formidable, skill more health workers and employ them? Because the discourse of community health workers in Africa has been kind of overshadowed by volunteerism. You know, rural women who probably have no other alternative for employment are picked and used to volunteer in homes and take care of others. It's a good thing, but we need, I think, to interrogate how much is it impacting on people who would have really gotten jobs. If they are going to be health workers for the sake of it, probably we need to think about having community health workers where it is just transitional. You're just the entry into the system, and then you are built to become a formally recognized kind of cadre, rather than just becoming a community health worker, no extra education, no hierarchy in terms of progression. As you mentioned earlier today, one of the reasons why health workers are jumping out is there is no room for growth. So if we are creating another static body or cadre that are there in community because they are there for lack of a better word or alternative, and then we say that they should be, we need to rethink that, especially the discourse of community health worker. I think having said that, it should mark the close of this webinar. The recordings are going to be made, and a report is going to be written, and presentations will also be prepared. I hope you have shared your email contacts for those whom we don't have their contacts. We'll be sharing this in the course of the coming days. Ladies and gentlemen, thank you so much for joining us. Once again, I want to announce that we would have another webinar in September on the 21st, which will focus on the decolonizing health research in Africa. Thank you so much.